Okay, Dr. Ravich here from Vet Triage. We are going through this January 15, 2015 issue of JAVMA, and today we are talking about the anesthesia case of the month. This study comes out of Veterinary College in Florida. So here's the first set of radiographs here. This is a Yorkshire Terrier. There you go. So 10-year-old Yorkshire Terrier, 6-month history of tracheal collapse. They were being treated with theophylline and butorphanol, increased coughing, respiratory distress, got treated with dexamethasone, sodium phosphate, and acepromazine and oxygen. He also had a 2 out of 6 left systolic heart murmur, cyanosis, palpably enlarged liver. CBC and biochemistry panel were normal. Thoracic radiographs showed extra and intrathoracic tracheal collapse with collapse of the principal bronchi, mild right-sided cardiomegaly, generalized hepatomegaly. Fluoroscopic examination of the thorax revealed severe dynamic extra and intrathoracic tracheal, principal bronchial, and caudal lobar bronchial collapse. The dog was treated with 40% oxygen, acepromazine, butorphanol, anesthetized for tracheal stent placement with butorphanol, propofol, oral tracheal intubation, isoflurane, oxygen. He was put on a Bain non-rebreathing system, lactated ringer solution, and then they placed an 8x72 millimeter intraluminal nitinol tracheal stent, and that's in this picture here. This is the stent right there. They placed by inserting the self-expanding stent in the delivery system within the lumen of the endotracheal tube. The stent extended from the mid-cervical through the cranial thoracic trachea. And so on the first radiographs here, they showed collapsed trachea, cardiomegaly. Now in these radiographs, you can see the tracheal stent, but the patient had respiratory issues afterwards. It's not very clear here, but this dog ended up developing pneumomediastinum, pneumothorax, and pneumoperitoneum. So they had to stabilize the dog, perform thoracocentesis, and they determined that this was iatrogenic, maybe occurred during stent placement by inadvertent puncture of the airway or the trachea with the tip of the stent delivery system or the introducer. So butorphanol, acepromazine, hydrocodone, homatropine, and thoracocentesis, albuterol, oxygen, and the dog went home in 2 days. Discussion. Tracheal collapse is a common problem in toy and small breed dogs, with Pomeranians, Yorkshire Terriers, miniature poodles, and pugs being most common. It's a structural disease of the trachea, caused airway obstruction with a dynamic component that affects the intra and extrathoracic portions of the trachea and mainstem bronchi. Tracheal collapse results from cartilaginous degeneration of the C-shaped tracheal rings that maintain normal patency. In affected dogs, the tracheal cartilages have decreased glycosamine glycan content, fewer chondrocytes, and decreased calcium concentrations compared with normal dogs. During respiration and the generation of normal airway pressures, the turgidity of the diseased trachea causes ventrodorsal collapse of the tracheal rings and subsequent mechanical obstruction, which perpetuates signs of chronic airway inflammation. Diagnosis is made by a combination of imaging, including radiographs, fluoroscopy, tracheoscopy, ultrasound. Collapse can be entirely tracheal and include the mainstem bronchi. Dogs often have signs of respiratory distress with a cough that's like a goose honk. Surgical management of tracheal collapse is considered a salvage procedure. 65 to 78% of dogs respond to medical therapy. Surgical procedures described for the treatment of collapse include tracheal ring chondrotomy, plication of the dorsal tracheal membrane, prosthetic mesh reconstruction, and intra and extraluminal prosthetic supports. And I've done the extraluminal supports before. They're terrible. Two-hour surgery, and I would say maybe 3/4 of them make it, but it's like really difficult. Nobody that I know does these surgeries anymore. Now they provide, they place stenting or do medical management. All surgical procedures are aimed at restoring airway patency and reducing airway resistance. The use of prosthetic supports is among the most commonly used treatments for collapsing trachea. Extraluminal prosthetic supports have been associated with severe complications like infection, nervous system and blood supply disruption, causing laryngeal paralysis, tracheal necrosis, and chronic coughing. A study found that 21% of dogs that had extraluminal tracheal prosthetics required a second surgery for treatment of unresolved respiratory distress attributable to post-operative laryngeal paralysis. In addition, use of extraluminal prosthesis is limited to treatment of tracheal collapse confined to the cervical portion of the trachea and tracheal inlet. So the extraluminal prosthetics does not let you get access to the intrathoracic portion of the collapsing trachea. Intraluminal stents have gained popularity in human medicine, where the stent is placed with obstructive tracheal disorder secondary to cancer in people. Use of intraluminal tracheal stenting originated from the application of stents designed for use with biliary, vascular, GI, and respiratory systems in people. Initially, balloon expanding stents were used, but these stents had a tendency to acutely recoil after the balloon was deflated, leading to stent migration and loss of luminal diameter. Since then, the advent and use of self-expanding stents made of various materials like stainless steel and nickel titanium alloys has been successful for dogs. Of the self-expanding stents, the Pomaz-Schatz stent has been associated with a high rate of complications, including pneumothorax, infection, mucus plugs, stent migration, compression of the upper stent ends. Another study reported the occurrences of pneumothorax in 2 rabbits with stent placement. Placing intraluminal prosthesis is accompanied by the use of rigid bronchoscopy into the trachea of a patient under anesthesia. The stent delivery system is then inserted into the trachea adjacent to the bronchoscope until the tip of the introducer can be seen. The bronchoscope is then partially retracted to allow for deployment of the stent. Once the stent is fully deployed, the bronchoscope is then carefully retracted, making sure to not disrupt stent placement. Following deployment, thoracic radiographs are taken to verify placement. Of the stents used today, those composed of shape memory alloys like nickel and titanium or nitinol have been found to be advantageous because they accommodate substantial strain before having irreversible deformation. A nitinol stent designed specifically for dogs and cats is made of woven nitinol material, classified as reconstrainable, foreshortening stent. So in a study examining the use of these stents for treatment of end-stage tracheal collapse in dogs, complications noted were dislodgement with retraction of the bronchoscope during partial stent deployment and pneumonia. A few anesthetic techniques to address the approach to general anesthesia for the placement of tracheal stents includes subcutaneous administration of glycopyrrolate, followed by anesthetic induction with thiopental and maintenance of anesthesia with isoflurane and oxygen in intubated patients. Others describe a total intravenous anesthetic method of propofol for induction and maintenance of anesthesia. One method of stent placement is to perform the procedure in a patient that is not intubated. Via this method and the insertion of a bronchoscope, oxygen, and the patient may be compromised if the narrowed tracheal lumen becomes obstructed by the bronchoscope. In patients in which intraluminal tracheal stenting is performed, when not intubated, a means by which to provide additional oxygen is necessary, oxygen supplementation may be provided by several techniques like flow-by, nasal oxygen via cannula, oxygen insufflation via transtracheal catheterization, with flow-by administration being the simplest method to provide oxygen for spontaneously breathing patients. A disadvantage of stent placement in intubated patients is limited visibility of the surgical site with a small diameter endotracheal tube and the inability to insert the bronchoscope through the lumen of a narrow endotracheal tube. Finally, pneumomediastinum is the presence of free gas within the mediastinal space and can be caused by penetrating neck wounds, esophageal or tracheal rupture or tear, venipuncture, or can be sequela of transtracheal wash. In dogs, the mediastinum is incomplete, and therefore there's a potential space between right and left pleural cavities. Several structures lie within the mediastinum, including the heart, trachea, esophagus, great vessels, lymphatics, vagus nerves, and thymus. The mediastinum communicates with the cervical fascial planes through the thoracic inlet cranially and with the retroperitoneal space through the aortic hiatus caudally. Pneumomediastinum can lead to pneumoperitoneum via air dissecting caudally through the retroperitoneal space, via the aortic hiatus, through the diaphragm. Pneumomediastinum can lead to pneumothorax, but pneumomediastinum will not result from pneumothorax because the air collapse the mediastinal space between the two pleural reflections. That made no sense. Pneumomediastinum may lead to pneumothorax, but pneumomediastinum will not result from pneumothorax because the air collapses the mediastinal space between the two pleural reflections. Right, exactly. So so pneumomediastinum is not something that you're going to directly treat. If you have pneumothorax, that's a concern and that's treatable. And then with pneumoperitoneum, it's not really a concern in a situation like this when you know that the air has traveled from the thoracic cavity into the abdomen and not and it's not from the abdominal cavity as the primary source. That's a different story. Pneumoperitoneum is almost always an emergency. So for veterinarians, key points here is to understand the anatomy between pneumomediastinum, pneumothorax, and pneumoperitoneum. And if you're studying as a surgery intern or surgery resident, you need to know all the different thoracic surgeries. Even though we don't perform them anymore these days, but you have to know them, all the pros and cons of each one, and techniques involved for that. And then for pet owners, tracheal collapse is something that you want to be a bit more aggressive about. You can probably see better outcomes with tracheal stent placement if you place those stents in dogs that are younger with tracheal collapse where they had more end-stage disease. They didn't comment on the liver and the heart in this study, but chances are that enlarged heart may be early onset core pulmonale. Heart failure is potential, and then hepatic congestion causing hepatomegaly is a concern. So if this Yorkie had the stent placement done maybe like 5 years prior, they may have prevented the secondary cardiac and hepatic changes, but they didn't comment on that here, which is unfortunate. You want to have these dogs have a complete workup. So if you see enlarged liver, get an ultrasound. If you see enlarged heart, get an echocardiogram before you dive into stent placement. So that's my takeaways for pet owners and actually for veterinarians as well. All right, we'll see you tomorrow. Bye-bye.